Okay, thank you very much to Dr. De La Fuente, and I'm going to be starting off with this mutational profiling section. A lot of this was very, very nicely discussed, and as Adolfo said, it's amazing to see how much discussion is focused on mutational and immunotherapy today compared to even 8-10 years ago, where a lot of discussion was focused around the doses of cytotoxic therapy and transplant. I think surely shows that we are progressing more into a molecular and hopefully eventually a immunotherapy era, as is seen in many other tumors. So this is the most, this is actually the 2017 version of the ELN, where you see that the patients were categorized into favorable, intermediate, adverse. The NCCN independently actually came up with a very similar classification that's used heavily in the United States. And basically, the key things here are, for the first time, the AML classification started to incorporate molecular mutation profiling as a standard approach. This was not research or only for academic centers. This was the standard approach recommended for every new acute myeloid leukemia patient that was seen in a community hospital, in an academic center, or elsewhere. And here it shows that FLT3 and NPM1 were included, and this is because there was significant prognostic data with these mutations helping to determine the role of allogeneic stem cell transplant. But also you see other mutations have started to become more and more important. TP53 that we discussed extensively, which is without a doubt probably one of, if not the most impactful single prognostic mutation, and others such as RUNX1, as well as ASXL1, as well as other cytogenetic abnormalities. So for the first time, it was kind of becoming a standard practice to do an extensive molecular profiling, at least for the top 6 or 7 genes, as well as cytogenetic classification. And as was shown, this actually did not only impact prognosis, but it also started impacting therapeutic decision-making, especially in the setting of FLT3, where we added a FLT3 inhibitor, core binding factor abnormalities, A21 inversion 16, where we added gemtuzumab, and now in the future, IDH inhibitors as well. So this is the very well-known and seen in hundreds of meetings paper, which was quite a seminal paper that for the first time in a large number of patients described the genomic landscape of mutations in newly diagnosed patients with acute myeloid leukemia. And it's important to note this was predominantly done in younger patients. This was actually a biobanking of samples from an ECOG study that included patients who are below 60 years of age. And so that's important to realize because the mutation profiles are slightly different from what has been published recently in older patients. So you see, for example, TP53 is 2% in our publications from MD Anderson, where we look at patients above 60 or 65. This is actually closer to about 16 to 20%, and others have also shown a similar thing. But the point here is that FLT3, NPM1, IDH1 and 2, and now maybe MLL, which are potentially targetable, make up somewhere between 40 to 50% of patients. So almost half of the patients newly diagnosed AML younger may have a potential targeted therapy approach that could be incorporated either in the front line or used in the salvage setting, and that's quite significant to identify because that could dramatically change the prognosis, the outcome, the treatment approach for your patient. So, as I mentioned, since that study was for patients below 60 years of age, we also wanted to know what is the mutation landscape in the larger population of AML that you see, right? Because majority of AML that we see are above 60, about 55 to 60% of patients. And here you see this was a very nice paper where the bars, if you look on the axis, it shows you the age below 45, 45 to 60, then up to above 70. And then you see the changes in the mutation over age. And you see a few of them are highlighted. IDH1, for example, seems to steadily increase with age. This is not surprising. We also know IDH1 is often associated with therapy-related or secondary AML phenotype, which also is more common in people as the age goes up. And TP53 also, as you see, is another mutation that goes up with age, probably because of a similar phenomenon of more therapy-related secondary AML in these patients. On the other hand, IDH2 seems to be quite stable from the age of 45 up to 70, 75. And in FLT3, which is very important, actually goes down, and this has been shown now in many, many papers that in the young, below 60 or 65, depending on which paper you see, where they call young at a different cutoff, FLT3 is probably up to 35% of the patients, 30 to 35%, but then as you go to above 65, it comes down to about 15% or so. And so this is important because one cannot just take mutational profiling as a homogeneous across different ages. It's impacted by age, it's impacted by de novo versus therapy-related secondary AML, and other factors. So this is kind of another version of what Adolfo showed. I think the point here is it's not one size fits all. We don't give everybody 3+7 or AZA, which is maybe 6 years ago, what kind of was our treatment option. This is not ancient history. Literally in 2016 or 15, those were the two key options, intensive chemo or HMA alone. But now we have much more personalization of therapy. APL, of course, has always had a unique status with arsenic, with very good outcomes, 95% plus survival, shown actually by the late Dr. Lococo from here and many other groups. And then FLT3 mutations, adding FLT3 inhibitors, initially midostaurin, now data with quizartinib, and then gilteritinib. I think we will see better and better outcomes. And then also therapy-related AML, MRC. We discussed this yesterday, kind of a unique group with a very different biology, and there are certain mutations that are important in this group, IDH1, TP53, MLL rearrangement, and identification of those mutations may help select optimal therapy. And then for others, as was mentioned, HMA-VEN versus intensive chemo is kind of the scales or the balance that we have to decide for each patient. I think in the U.S. at least above 70 and even above 65, the scales are heavily tipped towards HMA-VEN today. And the question is more about what can we do to make HMA-VEN better. And this is where the efforts are ongoing to add a drug or sequence a drug if you can find a targeted therapy, immunotherapy. And then intensive chemo, we're still using it definitely for below 60. That's still our go-to approach, especially in those who do not have TP53 adverse cytogenetics. But I would say it's becoming kind of a smaller, more niche population for intensive chemo in the young curative approaches. And then targeted therapies are now being incorporated in the frontline setting. Targeted therapies such as ivosidenib with AZA is now approved through the AGILE study. And then efforts also to see if we can combine VEN with targeted therapy. Venetoclax is a great drug that combines with very, very good variety of different drugs. So I'll stop here, and if there's anything in the chat or anybody has any questions.
To remember, very interesting things in the chat. You can also send questions, and you can also, the classic options of asking for the micro is also open. So, okay, we will move to the next talk, and we'll have the discussion, I think, later, everything together.
Yeah.
Oh, sorry.
Just a question, Bernie. Not really burning. In the morning, you cannot.
In the morning, nothing is burning. Exactly.
Is there any capacity of ivosidenib to target different mutation outside of the IDH1? I would like to understand if there is any evidence, any compound as an different capacity to do that. Yeah. Sorry.
Yeah.
Probably not. So it's not the same as like a pan-kinase inhibitor where you have off-target effects. This is, that it's designed to fit right within that IDH1 active site. It's been a question that has been, asked many times. There's never been studies of ivosidenib or enasidenib for that matter in IDH wild-type patients. In the very first phase 1 dose escalation study of ivosidenib, there were either 9 or 11, I forget exactly, but a few patients that actually on centralized review were not positive for the mutation, and none of them responded. None of them did. So
it's not explored.
It has not been explored, but there's not a lot of appetite to explore it based on that.
Yeah, I mean, I think the point, and you may be making this point, Dr. Martinelli, from FLT3 experience, right? But I think it's very different because, as we know, the FLT3 is heavily expressed on normal leukemia cells, right, regardless, and drugs like quizartinib have shown at high doses activity. But I think with IDH, it seems like more specific biology, but it's never been explored, so we don't know.
Yeah, but just on a comment regarding this. So in my understanding, if we are using a kinase inhibitor, it's possible that other kinases are also affected.
Exactly.
But in that case, what we are doing is just to inhibit the production of an enzyme, so the production of an oncometabolite. In case that this is not present, the mutation, probably there is no role. So
Yeah, I think for kinase and epigenetic, right, the menin inhibitors, it's a much more complex scenario where multiple leukemias may upregulate different genes or metabolic programs. I agree with, I think, more of a enzyme-directed therapy. It's unlikely, but, you know, you never know, so, yeah.
And also, well, regarding safety, it was also quite positive because the on-target side effects are few because there's no physiologic role.
Exactly. Okay, so we'll move to this next portion, and this is going to be kind of split between me and Dr. Donardo, and we're going to kind of try to go back and forth a little bit here, and if anybody has any questions, absolutely, please send them through chat, or you can go ahead and ask them as well. So this slide, I think you've already seen probably close to 10 times just at this meeting, and it's a very, very important progress step in the evolution of AML therapy. We think that eventually this may become kind of the way we go for large proportions of our leukemia, depending on how data matures from ongoing randomized studies. But this was specifically done in older unfit, which was defined using the Ferrara criteria that actually came out of Italy, and the FDA used those to say people above 75 years of age or with a very distinct documented comorbidity. So it was not investigator discretion or I feel this patient is unfit, or the oculometer. It was actually you had to have an EF below this, creatinine above this, DLCO below this, and those patients, when they were enrolled, showed a clear survival benefit as well as a clear CR, CRI, or CR rate. Any endpoint you look at was significantly improved, almost double with HMA-VEN versus HMA placebo, and this was an important step. But that being said, when you look at 1.5, 2 years, it's about 35% or so who are still alive. So definitely better than 10 or 15%, which is what we had historically, but we still want to do much better than just 35%. So good first step, but we need to build on it. It's important, I think, to understand the safety and tolerability profile. I think we've treated probably close to about 300 frontline patients at Anderson with HMA-VEN, and I think it's a very, very deliverable regimen, but we continue to learn in spite of having this much experience. And the main thing is neutropenia and thrombocytopenia, and you see that these rates are significant in patients who receive with HMA-VEN. Close to around 70-80% will have some degree of neutropenia and thrombocytopenia, double of what has been seen with placebo. It is quite manageable. Interruptions of dosing and, if needed, use of growth factors, and then shorter durations of venetoclax in subsequent cycles. These are probably the three key things that can help reduce the neutropenia and get patients to better count recovery, full CR, which is what we want with less prolonged neutropenia. And then briefly, and we'll talk about this more, I'm sure, as we get into the cases in the discussion, but FLT3 also has a unique standing. FLT3 was actually the first targetable mutation that went into clinical trials that led to the RATIFY study, randomized midostaurin 3+7 versus 3+7 placebo, showed a clear survival benefit. Now, at the end of the day, the magnitude of benefit is not as much as we would like. It's never as much as we would like, but it was there, and it was about 7 to 8%, and I think that's still very important philosophically to show that targeted therapy improved outcomes in AML, led to approval of the drug. But I do think we can probably do better with the second-generation FLT3 inhibitors, gilteritinib, quizartinib. Transplant still remains a very critical part of the AML treatment. As you see, even with the midostaurin study, the real benefit when you want clinical translation of the outcomes to really improve survival was in people who got midostaurin and went to transplant. That's when you start looking at 60, 65% or more for your survival, which is great given that FLT3 was historically considered adverse with a 5-year survival of about 25% when it was first described in 2001, 2002. So this is, I think, good progress, but again, more of the total therapy approach of targeted therapy, transplant, and then even maintenance post-transplant, which will further improve the outcomes. This is the Quantum First study, which was very recently shown 2-3 months ago at EHA by Dr. Harry Erba. And here you see that the survival is also improved. The magnitude seems to be potentially a little bit more. This study did include patients who were older. So this was 18 to 75, which is different from the RATIFY, which was 18 to 60. And I think we have to look at all the different subsets and the forest plots that will come out to get a better feeling of where this fits. Our experience at Anderson using quiz and Mido, and much more quiz actually, has been that it's very well tolerated. Actually, patients seem to like it better than midostaurin, doesn't have a weird taste, and we find it to be quite a potent drug. So we think that these data will hopefully lead to the extensive use of quizartinib in the frontline setting. Now, at the same time, while we're developing new frontline intensive chemos, I think there's also kind of a pendulum shift as to do we need intensive chemo for FLT3. And so that's where studies are now looking at combination of aza-ven with FLT3 to see if for your 65-year-old or 68-year-old patient, do you need to push them through anthracycline cytarabine, whether it's 3+7 or FLAG-IDA, plus a FLT3 inhibitor. Yes, you could probably get most of them through it. You're still probably going to have about a 15% early mortality, toxicity, mucositis, hair loss. And so with the HMA-VEN, I think we were not there yet. We were not comfortable that HMA-VEN doublet is going to be enough and this to overcome or replace intensive chemo in older unfit patients. And here you see that with HMA-VEN, the CR/CR rates are pretty good, but the survival is only 11.5 months. So it's still better than HMA. If this was the option I had, this is what I would do for my older unfit patient. But I still think that we definitely want to do better than that. And so that has led to these approaches combining either gilteritinib or quizartinib. These are the second-generation drugs, so these are the ones we chose to incorporate in frontline studies. Both of these are ongoing currently at MD Anderson. And the early data, very early data, this was like 11 patients or so that Dr. Short showed 100% CR rate. This will be actually at ASH with an update with 25 or so patients. The abstracts are going to be out in 4 or 5 days, so you can look at it. I will tell you the data looks outstanding. We're very, very excited about both the response and the survival now maturing and looking very, very good. So I do think this is the direction the field is going to move for frontline setting for FLT3. Of course, we have to know about myelosuppression, adjust doses, do all of the things, but the efficacy, I think, is going to outshine any issues with myelosuppression and problems. And we already started seeing this with some of our retrospective data. This was actually with first-generation FLT3 inhibitors. Most of these patients received either sorafenib or midostaurin, a few with gilteritinib added to HMA-VEN, and we were already seeing the signals that you're seeing much higher response rates, CR/CRi and CR rate, as well as MRD and molecular. And so I think using BCL2 inhibitor and targeted therapy together is probably the way to go forward. And of course, we need more mature data and larger studies are starting, but at least in the US, this looks like where people will be going. So at this point, if we have any questions in the chat and we want to take those, or if not, we can turn it over to Dr. DiNardo.